Let us talk about today's topic, which is basically the sympathetic overdrive which occurs in the body. And as a result of that, the patients will become hypertensive. And then do we treat them? So we need to understand the sympathetic overdrive. We need to see it in the context of hypertension. We need to see it as in the context of the therapeutic options that are available to us. And the beta blockers, how can they be utilized in those patients who have hypertension, which is associated with sympathetic overdrive? And then concentrate on the particular beta blocker, bisoprolol, in the treatment of hypertension. Perhaps this is the most important slide in this entire presentation. And I'll just try and explain a few things to you on this. I'll recollect what we were taught in our medical college days. When the hypothalamus is stimulated, the norepinephrine, adrenaline, which is secreted, it then stimulates the preganglionic nerves in the from T1 to actually L2 pathways. They then have their effect on the different systems of the body. Now, the sympathetic neural factors, they're actually involved in multiple homeostatic functions, and there's a balance which is created between the energy balance and the blood pressure control. This system becomes activated in a flight and fright condition. And when that happens, we all know what happens to the pupils. There's a mydriasis, or the pupils are dilated. Then if you look at the heart and the lungs, in the heart we have the beta-1 receptors, which are located at the conduction system pathway, and then you have them in the myocardial cells. And there is a stimulation of one receptors here in the heart rate. That increases the stroke, and that increases the blood pressure. And then you have an effect upon the myocardial cells, which then contract more vigorously, and then there is an increased contractility, the stroke volume increases, and there is an increase in the cardiac output, which results in an increase in the blood pressure. So in a situation of stress, what is needed is an increase in the heart rate, an increase in the circulation, an increase in the blood pressure to cope up with it. Then the beta-2 receptors, which are located in the lungs, they are stimulated, and this then results in bronchodilation, which increases the flow of air into the lungs, and that increases the oxygenation of the blood that is being circulated there. So that is the effect that we have. And what we need to do is that whenever we are giving them beta blockers to reduce the blood pressure, to reduce the heart rate, we need to do it in a selective manner on the heart, and hopefully try to avoid it being the lungs being affected, or the beta-2 being stimulated. And unfortunately, if you give it in a higher dose, there is some effect, even with the cardioselective beta blockers, on the beta-2 receptors in the lungs. Then there is an effect upon the GI system, which then results, there's an inhibition of peristalsis, so that that energy is conserved, and the energy which is needed to cope up with the stressful condition then is carried to needed. It also affects the pancreas, where there is an increase in the secretion of glucagon, and this then has an effect upon the liver, and it increases uh, glucose through the two processes of gluconeogenesis and glycogenolysis, and that to provide the energy to the body. And then it also the beta-1 receptors, which are here in the kidney at the juxtaglomerular apparatus, they are then stimulated. Renin is released, and then you have angiotensinogen from the liver, and this renin then acts on it, converts it into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by the ACE converting enzyme, by the angiotensin converting enzyme, and this then acts on the 82 receptors, causing vasoconstriction. And in fact, all the deleterious effects that are associated with the stimulation of the renin angiotensin aldosterone system, as a result of which there is a reabsorption of sodium and of water. So these are the effects which take place in the body as a result of sympathetic overdrive. Now, as a result of sympathetic overdrive, there's an increase in the sympathetic nervous system activity, and there's an increase in the renin angiotensin aldosterone activity. A chronic sympathetic activation actually has been implicated in the development of a metabolic syndrome and other cardiovascular risk factors. And it is actually, the drive is triggered by reflex mechanisms like arterial baroreceptor impairment, which affects it, and then metabolic factors, insulin resistance, and humoral factors. So after we have understood this particular system, as a result of which there is an effect upon the heart, upon the lungs, on the different organs of the body, on the kidney, what really happens when there is a sympathetic overactivity? It increases the heart rate. That is number one. And that has an effect upon the arterial wall stress, the LV apoptosis, endothelial dysfunction, there's an LV stiffness, and it all results in heart failure. Then there is a combination. If sympathetic overactivity results into hypertension, it also has an effect of creating insulin resistance, and in fact, sympathetic overactivity and obesity, they interact with each other, and this triad is known as the cardiometabolic syndrome. And as a result of this, there are coronary events, there are lipid abnormalities which take place, inflammation, which is now being considered the hallmark, vasculopathy which occurs in the entire system, even as a result of the COVID-19 infection. That is basically the main the pathological feature that occurs, which results in the cytokine storm and the death in these individuals. That is just, by the way, the comment I made, but the triad here results into, or it can cause sudden death. It can be because of the heart failure, which is occurring because as a result of all these changes and the other changes which occur on the left side here, resulting in coronary events and sudden death in these individuals. Now, as I pointed out earlier, the sympathetic nervous system activity, increased activity, results in a neural release of norepinephrine, and this then has an effect upon the beta-1 receptor stimulation. There is an increase in heart rate. There is a decrease in the heart rate variability, and the contractility increases because of the effect upon the cells. Then the release of norepinephrine here on the kidneys at the juxtaglomerular apparatus, where there is an increase in renin, as I said to you, angiotensin is increased, the blood pressure rises. As a result of the rise in blood pressure, there is left ventricular hypertrophy and heart failure. And on both sides, when they are acting together, there is a mechanical and a vascular damage. There's an endothelial dysfunction, and as a result of that, there is a vascular damage which occurs, resulting in, it augments atherosclerosis. There can be a plaque rupture in a stressful condition, which we have all noticed, that whenever there is sometimes a severe grievance which occurs in the family, or any other incidents which is there, this can cause a sudden rupture of the plaque, which may be a small one, and which results in an infarction, and there's always a risk of sudden death in these individuals. So this is how the sympathetic nervous system overactivity can create cardiovascular problems in our bodies. And as a result of this activation, you will see that the heart rate increases. As I told you earlier on, there is a stimulation of the renin-angiotensin system. The myocardial reserve is reduced, and all these actions which take place as a result of this increased sympathetic nervous system activity, they result into these changes which occur at different levels and result in arrhythmia risk, cardiac dysfunction, ischemia, and as a result of that, the patients can develop heart failure and sudden death. So overactivity of the sympathetic nervous system can have devastating effects upon the body system. Now, when we see type 2 diabetes, but we must understand that we cannot actually compartmentalize different conditions. They actually crosstalk to each other, all of them. So in type 2 diabetes, there's an insulin resistance, there is increased insulin production, norepinephrine release is increased, and all this results in ventricular arrhythmias, increased plasma renin activity, the angiotensin 2, which has very severe deleterious effect upon the entire body, that increases, and these are the changes which take place in the body as a result of that. The same is happening with the increase in the sympathetic activity of the cardiovascular system, and in type 2 diabetes also, there is a similar effect that is being seen in the body system. So now when we look at let me just get this away from here. So now when we look at the sympathetic overdrive in patients with diabetes and hypertension, you will see with essential hypertension and diabetes, the sympathetic activity is increased. If it is just hypertension, it is less with diabetes, but when you combine the two, it is markedly increased. The sympathetic overactivity is increased in these patients. I think there's some problem with my slide, which are not moving forward. How will I get back to it? Khaled, is the way that maybe now it is.
I will request from Mr. Zaid to help Dr.
Okay, now the slide has moved forward. You see, even in an acute mental stress, you will find that there are a number on here, but then you have contribution to the perfusion, limitation, and ischemia. All these effects are there, which increase the risk of cardiovascular disease. Now, in those patients who are centrally obese, you will find that there are certain changes which take place in the system, like production of the vascular toxic adipokines, endothelial inflammatory response, and the production of leptin. They're all increased in those people who have central obesity. There is an endothelial dysfunction and insulin resistance, and this then results into an activation of the sympathetic. So all these factors which I'm referring to, diabetes, obesity, they are actually increasing the sympathetic nervous system. Diabetes and obesity, you will find that there is a much greater increase in the sympathetic activity than when they are existing alone. And normally they don't exist alone. It's a triad which is there. Another, just as a information, what I would just like to pass on is that those individuals who are obese and unfortunately contract COVID-19 and they are put on a ventilator, their prognosis is worse than those who have a body mass index which is normal. Now, when we look at the sympathetic nerve activity, we'll find that it is increased in those who are centrally obese. It is also there in peripherally obese, but it is least in those who are lean, who are thin. And also in smokers also, there is an increase in the heart rate and blood pressure, and that also actually augments the sympathetic nervous system. So smokers, diabetic, obese, all these individuals, hypertensives, they have an increased sympathetic activity, which causes all the problems to them. And whenever you have an increase, you'll find that it was seen in this experiment where the norepinephrine was higher in those who were smokers as compared to the ones who were sham smokers. So we have tried to understand what the sympathetic overdrive is, how it is affected by the different conditions, hypertension, diabetes, obesity, smoking. And now let us see what it does to blood pressure. And when we look at that, according to the Framingham study, this is very interesting that when you have a blood pressure which is less than 55 years, that is more of a diastolic blood pressure. And the blood pressure which is after 55 is more of a systolic hypertension. And the predictors of diastolic hypertension are young age, male sex, a high BMI at baseline, and increasing BMI. Now, in the elderly population, where you have isolated systolic hypertension, this is a little bit more difficult to treat because here you have an increased arterial stiffness. There's an aging of the arteries which you can't reverse. And in the diastolic hypertension, there's an increase in the peripheral resistance. So in the younger individuals, what the case I'm trying to build here is that since the younger individuals or the middle-aged patients, they have a sympathetic overdrive. So even if the guidelines do not recommend the use of beta blockers, we can make a case for that. And a very important case which I feel is that when we say that the beta blockers have no role in the treatment of hypertension or in the treatment of cardiovascular diseases, what we are doing is we are throwing the child out, the baby out with the bath water. And this should not be done because there are cases, there are instances where you can use beta blockers in the treatment of your patients with hypertension. And I think this we have to keep in mind. Now, when we look at the heart rate in our patients, we'll find that if the heart rate is low, they have actually a much better prognosis as compared to those who have a higher heart rate. So we need to actually control the heart rate, and all of us who are treating patients with hypertension and heart failure know that if in heart failure especially, we need to keep the heart rate down. That will actually reduce the incidence of events in them. That will also reduce the incidence of rehospitalization in these patients. And when we look at the risk of cardiovascular mortality at the different heart rates, you will find that when the heart rate is less, the incidence of coronary heart disease, cardiovascular disease, all-cause mortality is reduced in comparison to when the heart rate goes up beyond 70. And at beyond 80, you will find that it is much more increased. There's an increased incidence of coronary heart disease, cardiovascular disease, and all-cause mortality in our patients. Similarly, we will see that there's an increased mortality risk with increased heart rate it was seen amongst the French men according to age, less than 55. The same thing was seen that if the heart rate is higher in these younger individuals, there is an increased relative risk of death, which can be seen in these individuals with higher heart rate. Similarly, there is a 3.8-fold increase in the risk of sudden death compared with the lowest heart rate quintiles. That is what was shown here in a group of patients, 7,000 patients in this age group who were followed for an average of 23 years.